I'll register using your Gmail, and then that's how I pull them out of place here. It took me a panic attack. Oh, I think these are done.
I'm like,
I'm definitely ready. We're looking at it.
you're doing great there. Don't worry.
Like, let's say, how did we get here? Are you leaning towards this side or the other?
It's like so good.
Like, are you leaning towards?
For those that are joining us on Zoom, are you guys able to hear? If you could just put a thumbs up or put a,
Yeah.
Thanks, Josiah.
Rob, there's a seat right here. Okay, I think we're gonna get started, everyone. Okay, so it's my privilege today to introduce Dr. Julia Lynch. She is a professor of political science at nearby Penn. She's an internationally recognized expert in the politics of public health, social policy, and inequality in affluent democracies, particularly in Western Europe and North America. Dr. Lynch earned her PhD in political science from the University of California at Berkeley. As a Berkeley person, yeah, go Bears. This person from Berkeley, very happy to hear that. She graduated magna cum laude with a bachelor's in government from Harvard. And at Penn, she is serving as a faculty and the co-director of the Center for Excellence in Teaching, Learning, and Innovation, as a member of the advisory board of the Leonard Institute. In addition, so Dr. Lynch's recent scholarship includes widely acclaimed books such as The Regime of Inequality, The Political Economy of Health and Wealth, Unequal Pandemic, COVID-19 and Health Inequalities, and the fourth theme, Getting Better, the Policy and Politics of Reducing Health Inequalities. Her influential work also features a major 2023 review article on the political economy of health in the annual review of political science. And I will say that during the pandemic, Usama and I read a lot of Dr. Lynch's work, and I can't tell you the number of Slacks we sent back and forth, little like emoji, mind blown comments. So much of her work just made us really think about new ideas and concepts. So we are incredibly thrilled to have you here. And so please join me in welcoming Dr. Lynch.
Thank you so much. It's great to be here. It's so close and yet so far. I haven't been over on your campus in probably close to 10 years. And this school has changed so much in the intervening time, and I'm really excited to be here, having a great time meeting folks. So really can't thank you enough for the invitation. Thank you, Lisa. So I'm going to talk to you today as a trespasser. As a political scientist who spends a lot of time working with social epi folks and sort of in and around public health, but definitely as a political scientist today. And I'm going to talk to you about clouds I think this is the first time I've ever used anything even close to a biblical allusion in any of my talks. So, here we go. Nope. We'll do it the old fashioned way. Also no. Thank you. Okay, so what I'm gonna do today briefly is I'm gonna talk about what I mean by political economy of health. I'm gonna talk about how I think a political economy approach can be helpful to social epi folks as we try to unpack some of these big structural upstream determinants of health. And then talk a little bit about why I think it's important to do this. So anybody who reads sort of in the critical public health journals, you know, where all the cool kids are, like you've heard of political economy of health. But even political scientists, I think, are often not really clear about what we mean by political economy. And I think that confusion only grows when we move outside of political science. So just as kind of a primer to how we think about political economy within political science, there are kind of four basic ways that people would use this term. One is, you know, using the methods of economics to try to understand political problems. And that's kind of the dominant understanding among professional political scientists right now. Another way to think about what political economy means is thinking about politics as a process of interest maximization. So, you know, this kind of goes along with often with a kind of pluralist conception of politics where everybody is out there kind of in the marketplace of ideas or in the marketplace of policy, trying to kind of maximize their interests. Another way to think about political economy is to think about the political forces that drive economic policy and other sort of related policy choices. And that's kind of the closest to where I come down probably in today's talk. And then finally, the most kind of critical version of political economy, which I think is what you do see kind of reflected in public health conversations most, is the idea of political economy as a critique of neoliberal capitalism in particular, but also of things like racism and colonialism, and the effects that this has on outcomes that we care about. So my definition of political economy of health in regimes of inequality and in related work is that it's a way of understanding how the organization of politics, of society, of the economy influences the distribution of upstream non-medical determinants of health. So not just non-medical, but also like moving a little bit further upstream than most of the kind of main social determinants of health that you might see on, you know, the Robert Wood Johnson Foundation's website or something. And the key is getting at how the organization of politics, society, and the economy does this influencing. What are the mechanisms through which it happens? And in my annual review piece, I talk about some of those mechanisms. So the articulation and representation of interests through things like elections and lobbying and, you know, labor organizations. Through government action or inaction to shape the economy, which in turn has these downstream effects. Through the translation of economic power into political and health resources, and through communities' actions to reshape the institutions that govern them, that govern society and the economy. So these, I think, are sort of the four main mechanisms that we might want to think about, or the four main types of mechanisms that we might want to think about when we think about political economy and public health. And I'm going to come back to the idea of mechanisms in a little bit. Okay, so most of the time, I think when we think about the sort of political economy of health, we're kind of stuck down here in the policy level. The health equity policy tool is something that I've helped to develop for the World Health Organization. It's always frustratingly downstream for me. Even though it looks at a really wide range of policies and a really wide range of things that we know can have an impact on health and on health equity, everything from, you know, social policy, gender-related policies, immigration policy, trade policy, these kinds of social, you know, what we're now calling commercial determinants of health, still kind of fairly far downstream. Moving a little bit upstream, we have recent work from Daniel Dawes, which I think is really excellent and highly commend. This is his diagram of the political determinants of health. It's super complicated. The main thing I want you to notice is that it's got a lot of arrows, and it's pretty complicated. This is not how I think about politics. Over here on the left are some of the major factors in politics that I think are really worth paying attention to, and that have been shown in the literature and public health to have a big impact on health and health equity. Regime type. What kind of government organization are you living through? Is it a democracy? Good question. What kinds of legal institutions are out there, and how do they shape everything from, you know, property rights to access to the vote? How do people behave politically? Who gets to vote? Who's alive to vote? What kind of government you have? What does it want? What are its beliefs? And how does it turn those beliefs and ideologies into policy? And finally, how are health issues in particular politicized or polarized? These are all, I think, really important factors in thinking about the political determinants of health. Well, so next I want to turn to how do health organizations think about some of these more upstream political determinants of health alongside some of the other economic or upstream social or economic determinants. And here's where I think iconography is really important. I'm very influenced by a long ago article by Nancy Krieger on the iconography of public health in Journal of Epidemiology and Community Health. It's just a great piece. Pictures matter a lot for public health, right? So what do we have? We've got rainbows, rivers, and icebergs, I think, are our three main categories here. The rainbow image, I'm sure you are all familiar with. The European Science Agency actually named this as one of the most influential science communication images of all time. So the sort of purple-violet part of the rainbow here is these general socioeconomic, cultural, and environmental conditions. Okay, well, that's not super specific. We know we're supposed to pay attention to them, but like, how? Maybe we can go to a river. Maybe that will help us. This is your standard river diagram. I've included one in every book I've ever written. They all look a little different. Some of them have tadpoles and cattails, and you know, others just have policies, right? So here we're looking at these far upstream political structures and institutional practices that assure fairness and opportunity for all. Let's get a little more specific. That's telling us where we might look to find the teeth in some of these upstream determinants. Oh, and then we have the health promotion iceberg, which looks super scary. And what could be scarier than economic and social structures, right? This very low down stuff in the iceberg that might get you if you're not careful. Local, regional, national, and global power and wealth distribution, fiscal policy, gender, and class. So I think this iconography in public health communications about the upstream determinants of health can help us, can help direct us usefully towards large things out there in the world that might get us in terms of creating poor health or health inequities. I think we can get a little more specific. Many people are now referring to these as structural determinants of health. This image, capitalism is not healthy for children and other living things, is a very straightforward statement of what it is that's the problem and why it's a problem. So some of these big structural determinants of health are things like structural racism and sexism, colonialism, dependency, globalization, capitalism, neoliberalism. These are sort of the major suspects that we see kind of in the literature here. So I want to argue that we should think about these things not as rainbows, rivers, or icebergs, but instead as clouds. So these are cirrus clouds. I was a weather nerd as a child, so I happen to know this. Cirrus clouds are way high up. They're some of the highest clouds that we see. They're made of little ice crystals, and that's why they have this wispy look about them. So why are structural determinants of health like clouds? So first of all, they're really far upstream, like the cirrus clouds. They are so far upstream that they in fact structure other determinants of health. They may be fundamental causes in Lincoln Field's terminology, in the sense that they act through multiple pathways and multiple mechanisms to produce health inequities. They tell us something about power. Clouds don't tell us anything about power, but there the analogy begins to break down. That's what makes determinants of health structural. They're aggregates. They're made up of lots of little teeny tiny ice crystals, right? They look like a cloud, but they're actually aggregates. They look like a thing, but there's actually lots of little teeny tiny pieces that make them up. And finally, they are nebulous and squishy. And this, I think, is the key characteristic, not only that makes them like clouds, but that is important for us to remember. The structural determinants of health are not solid things that you can touch. They are nebulous and squishy. And we need to approach them as nebulous, squishy things and deal with them in that light, or else we're not going to make a whole lot of progress. So I want to make the argument to you that when we are dealing with nebulous, squishy things, we can draw some inspiration and maybe even some help from political science, and in particular from parts of political science ontology, epistemology, and methodology. I'm going to go through each of these in turn. So I'm going to do this using an example. The example is social democracy. So if you've paid any attention at all, you've probably seen that not just now, but going back to the 1990s, there's quite a lot of literature in public health that argues that social democracy as a political, economic, and social system is really good for health. And it tends to, when you have a society that's sort of organized around social democracy, health inequalities tend to be smaller. And in fact, Seth Berkowitz has a book just out, Equal Care, Health Equity, Social Democracy, and the Egalitarian State. So this is not old, it's not just old news, it's new news as well. We love social democracy. Okay. How do we deal with social democracy? It's not really a thing you can touch. So ontologically, like when we think about what is the nature of things in the world, ontologically, we need to ask, what is social democracy? What part of social democracy, this aggregate, this squishy, nebulous aggregate of things, is it that's actually doing the work to create health equity? It might be more than one thing, and that's fine. But first we need to understand, what is it? What is the nature of this thing? And I would argue, as someone who has studied European politics for a long time, that social democracy is an aggregate of ideology, political parties, particular social democratic politicians like Olof Palme, who was the head of the Social Democratic Party in Sweden for a long time, social democratic policies, and actually social democratic regimes, which kind of goes beyond individual policies, but talks about the way that aggregates of policies kind of hang together within social democracy. So we need to understand that social democracy as an ontological matter is an aggregate. It's not this thing that you can point to in a regression table. And believe me, public health researchers have done this, right? But you actually have to pick it apart and try to figure out what it is, what's doing the work. So secondly, at an epistemological level, sort of in terms of how do we know things, right? How do we understand, how do we come to understand things that happen in the world? I think we really need to understand the mechanisms of action that tell us how we get from whatever piece of that thing called social democracy, whether it's the ideology or the policy, you know, maybe it's an ideology of equality. Maybe that's all it is, right? Or maybe it's actually a policy of full employment that's doing the work. Or maybe it's Olof Palme himself, who just thinks health is really, really important. We don't know. But once we decide what we want to focus on, we need to think about, okay, what are the mechanisms of action? How do we get from one thing to the next? This is from an old piece headed by Vicente Navarro from 2006. And, you know, I don't want to throw anybody under the bus, but this is not like a super sophisticated understanding of the political mechanisms that get you from an aggregate sort of political phenomenon like social democracy to health outcomes, right? Really, we go to labor market and the welfare state to economic inequality to health outcomes. Like, first of all, you know, is there maybe something missing there? Like, but also, is this really all that's going on? So I think we need to be a lot more specific when we are spelling out our mechanisms about how we get from a specific element of social democracy to a specific outcome, whether it's life expectancy at birth, which is what they're studying here, or whether it is you know, the comparatively small size of relative inequalities in healthy life expectancy among men, right? And these are probably two different mechanisms. And so really spelling out carefully both your starting point and your end point and how you get from one to the other. It sounds very obvious, but in a discipline that's obsessively focused on causal inference, as mine is, and as yours is, sometimes we lose sight of the fact that mechanisms are actually what we're after. It's not just the cause and the effect that we're interested in, it's actually the mechanism. Okay. Two kinds of mechanisms that I think political science has taught us. Political science being, in this case, sort of historical institutionalist methodology, tells us that there are two kinds of mechanisms that we really ought to keep an eye on. One is the mechanisms of action, right? So how do we get from whatever piece of social democracy we think is important to whatever our outcome is? But the other is mechanisms of reproduction. What keeps social democracy in place, or what keeps that particular element of social democracy in place for long enough to have its effects, right? And epidemiologists are wonderful because you understand the notion of an etiological period, right? Which political scientists sometimes are a little fuzzy on. But like you are beautifully positioned disciplinarily to take advantage of this idea of mechanisms of reproduction. And this is a really, like, I think a really important insight from public health that needs to be imported into political science. But for those of you in public health, sort of thinking about it as a mechanism of reproduction, I think, you know, may be an important sort of mental shift. Social democracy does not stick around forever, even in Sweden. Okay. Finally, in terms of methodology and method, like how do we go about measuring both the inputs and the outputs and the mechanisms that we're interested in? And how do we make inferences based on that? Well, let me ask you a really simple question. What's the relationship between social democracy and COVID-19? Well, in 2020, Tom Popinski, who is one of my favorite political scientists, really, really smart guy, in no way do I want to throw him under the bus. Tom Popinski prepared this delightful graph for us, showing a very strong correlation between social democratic capitalism, sort of one core element of social democracy, and confirmed COVID cases per 1,000 people. And your social democracies are down here. Really nice. Everybody knows that the social democracies are going to do so much better when it comes to COVID, right? So April 27th, 2020. So when we talk about mechanisms, this is just like the most obvious possible case, saying we need to be modest about our claims. We need to have scope conditions, and we need to think about whether the mechanisms that we're talking about are good for all time or only in certain periods of time. I think you all know the end of this story, which was let her rip and very high COVID, both death rates and case rates in Sweden compared to other places. All right, another way that I think we really need to be careful about contextualizing both mechanisms and outcomes is socio-demographically. So we need to think about the temporal context. We also need to think about the socio-demographic context. Do the same mechanisms work in the same way for all of the different socio-demographic groups that we might be interested in? I think this is something that social epi folks are generally pretty good about. Just to note that even in this period from 2020 to 2022 in Sweden, there was a lot of sort of differentiated stuff going on. Turns out that one of the big reasons why Sweden ended up having such high fatality rates is that the majority of the workers in Swedish care homes were immigrants. Immigrants were not receiving health information in a language that they understood well. And then they were going into the care homes and essentially killing their patients. So this question of sort of language problems, 182 medically authorized interpreters across all of Sweden, when Sweden has a population that's 20% immigrant. That's just not enough, right? All right, finally, spatial contextualization. What we have here is a nice campaign button for the Social Democratic Party of America. So my question for you is, you think a Social Democratic Party, if it had a majority in Congress in the US, so let's just suspend our disbelief for a moment, would it be able to improve population health and health equity? Why or why not, right? What if we elected a Social Democratic Party? What are the surrounding institutions, ideologies, party systems, degrees of political polarization, et cetera, that would impact the effect that a Social Democratic Party that, let's say, shared 100% of the ideology with the Swedish Social Democratic Party circa 1975. Would it be able to accomplish the same things in the US? So spatial contextualization, obviously, it's not about space per se. It's about units of analysis, right? So whatever your unit of analysis is, whether it's cities, whether it's countries, whether it's neighborhoods, whether it's community groups, whether it's ethnic groups, right? We need to contextualize and understand how these mechanisms work. Okay, so I'm going to close with why I think we need a political economy of health approach. So I've just sort of talked to you for about a half hour about how political scientists might approach this. And I think coming from within political science, there are good reasons why public health needs a political science approach. It's so that you can talk back to us, right? And tell us how to do our job better. So I think political scientists, and I take myself as an object lesson, can benefit tremendously from collaborating with public health specialists. You avoid the problem of the Tom Popinski blog, where you kind of add a health variable and stir, and don't really sort of think that hard. I was on a number of funding committees during COVID, and the amount of, I have a research agenda, I've just discovered that public health comes with numbers. And I can put those numbers into my research agenda, stir and spit something out the other end. There was a lot of that, and we can do better in political science, but we need to learn from folks in public health, social epi, population health. So please, invite us to work with you, even if you think we're dumb. The other way that I think this collaboration could be really beneficial for political science is that political science as a discipline is really, really shy about looking at power. We really don't like to talk about that. It's sort of unseemly. If you're too focused on power in political science, you get kind of branded as a radical and as a troublemaker. And I think in public health, you don't have that problem. And it would be nice if we could learn a little bit from that as a discipline and say, oh, maybe the stuff that actually matters is power, and we should think about how it works. But that's for me. What does this do for you? So I think as scholars, we can have a conversation, right, about the ways that collaborating with political scientists and using political science insights to really think about the impact of policy on health, to think about, how to do that better. But I think when it comes to health, it is really important to figure out a way to promote structural competency, right? We all need to be better at understanding how structure works, what these cirrus clouds have to do with what we're observing on the ground. One of the things that I noticed as I was preparing for today's talk and meetings, reading over the bios of the faculty members who I'm meeting with today, fascinating. So many of the same problems that I've been thinking about, super, super interesting. And then I go and I look at the CVs. And the CVs are full of these micro level papers with teeny tiny little outcomes without a lot of politics in them, and sort of trying to figure out how to bridge the gap between these big questions that you have about power and policy and the impact that that has on health, and the kind of publication that you need to do to keep yourself in business. That gap is large. And I think that better training in structural competency, which involves some amount of theory, might actually help to bridge that gap. And I think, one key piece of that theory that's worth keeping in mind is that politics is everywhere all the time. politics is not something that just happens, you know, to create bad things, right? It's not only politics when, you know, right-wing authoritarians come to power. Like, there's also politics happening before then. Politics structures everything about health. And so the better your theories about politics are, the better able to analyze health and the impact of big structural determinants on health you're going to be. So I think structural competency, a big part of that is learning about the theories that other disciplines use to understand power and politics, not just political science, by the way. Sociologists, anthropologists, public policy scholars have something to say about this too. So structural competency, just a definition here, the trained ability to recognize and respond to public health as an outcome of laws, policy systems, and institutions, from a great piece by Westbrook and Harvey. So it's not just about studying it. You know, those of you who are on the front lines also probably want to be able to respond to this stuff. And I think structural competency is arguably even more important for people on the front lines and people who are in communication and in dialogue with community organizations, figuring out how to share information about structures and how they impact people's lives is a really important part of doing good frontline public health work. The end. So we have plenty of time for questions. Okay. In the back, what's your name?
Hi, I'm Gabe Schwartz. I'm so happy to be here and that you're here. I wanted to ask you a little bit more on the last point you made about responding. Because I think you were talking, I think a lot of the reason people are here is like, how do I think about politics as an etiologic factor? And not how do I influence politics with my research? That there's like, it's like unidirectional. Right, like I need to understand politics to describe this pattern better. And at the end, I will publish an academic journal and I will send a policy memo to 4 leftist policymakers. And hopefully that somehow results in a change. So could you talk more about just like thinking about how that response works and how this way of thinking maybe helps us respond practically in a way that has better outcomes?
Yeah, this is a great question. So I have a joke for you. You ready? Evidence-based policymaking. Right? So there's no such thing. We know this. So understanding if policymaking is not based on evidence, what is it based on? Right? And here, the public policy literature in particular, far more than political science, I think, has really good answers. So it's based on networks. It's based on personal connections. It's based on taking advantage of a window of opportunity, which means having things prepared ahead of time. So the public policy literature is full of like really applicable how-to information. Which kind of gets around this issue of the fact that there is no such thing as evidence-based policymaking. The other thing that I would say, just to keep it brief, is that to go back to my point that politics is everywhere, right? And so you are doing politics when you're working with a community group and helping them understand structures, or listening to a community group tell you about their understanding of structures, and then taking that back to, you know, your DSA group or your 4 leftist policymakers who you might be in contact with, right? So, or, you know, during the pandemic, I worked on writing a constitution for a scarce resource allocation team in a VA medical center, which allowed them to actually hear the voices and act on the voices of people who would normally be shut out of medical decision-making, right? That was a hugely political undertaking, and I did it because the guy who was asked to stand up this committee, who was a physician, knew me from previous work and was like, oh, I need a decision-making structure. I need a political scientist, right? So politics is everywhere in health. And it's not just about having an impact through a conversation with an actual policymaker. So I would encourage you to think not only about how can you be more impactful with policymakers and the staffers and that kind of stuff, which really comes out very strongly in the public policy literature, but also about how the other work that you do is political and can have an impact.
We'll do an online question now. Do you have any recommendations for scholars who have written on structural competency in public health and or institutes provide training seminars?
Well, I'm not sure if the slides are going to be made available to you. Okay, but the last slide actually provides an example of both. Westbrook and Marie, I think, have done some really good work on structural competency. It's starting to be integrated into public health textbooks now. So, you know, even in some kind of standard textbooks, you'll start to see that. And then UC Santa Cruz has done some nice trainings. Beyond that, you know, I'm sort of not sure who's operating in that landscape at this moment. But as I was talking with Leah earlier today, sorry, I lost the thread connecting to what I was talking about with Leah and why that's related to structural competency. Oh, I think it was just the idea that collaboration is really important, right? And there are people who have devoted their lives to understanding certain political systems, certain policymaking environments. And sometimes they are scholars, people like me. Sometimes they are members of the community who live in those places and who have a really good understanding of how to make things happen. And so I think making sure that you're talking with people, whether it's other scholars in other disciplines or members of the community or public health professionals who work in a particular place, just getting some of that expertise about the local context helps you with those contextualization issues that we talked about. And that is really kind of at the core of structural competency.
Hi, I'm Anna Diazor. Nice to meet you. Thank you so much for coming. So getting back to Gabe's question, because I think it's a really important question. I mean, coming from another country, I sort of grew up in an environment where it was obvious that evidence was not going to impact policy.
Right.
So no one had that belief. If we were on the other extreme, so we never generated any evidence. But on the other hand, it was true that there was a clear understanding that, you know, policy and political decisions are based on other things.
Right.
That also have to do with paradigms, ideology, social movements, public perceptions, worldviews. And so I wonder if you have, you know, any thoughts. I mean, you know, I think there are ways in which our research can shift those views gradually. You know, there's a really nice paper by social scientists, I can't remember their name right now, but I like them a lot, about the uses of evidence. And one use that they highlight is the use to sort of generate new insights, paradigm changing, opening up public, you know, the possibility that we might actually have to do something to intervene on the dynamics of capitalism, for example, which, not because people are bad or greedy, has adverse health impacts because of the way it functions. That's the system, right? So sort of opening up our worldview to consider other policies that we would not, that the public would not even consider before, as another way in which, you know, evidence can help move us in a different direction.
I think that's true. And I think doing that kind of work so that when the window of opportunity for policymaking opens, you're ready to move is really, really important. But as a sort of counterpoint, I think it's also really important that we recognize to what extent our research and things as basic as the categories that we use and the models that we construct very often perpetuate the ideologies that we are trying to overcome, right? So, you know, just as an example from my own work, I'm currently working on a book that looks at how governments measure socio-demographic characteristics in ways that can be connected to health data, because this is how governments can see health inequalities, right? Well, epidemiologists are key to this process, right? They have a huge impact on how governments decide to collect this information, particularly in the contemporary period. So on the one hand, having a really clear vision in your mind about what you want to achieve, as you suggest, Anna, can help open up new possibilities. The flip side to that is if you're not paying attention, right? If you're not paying attention to the ways that the sort of categories of understanding or categories of measurement or types of models that you use may sort of perpetuate models of the world that you just inherited without a lot of thought, then you can end up doing some damage too. So I think it's important to be cognizant of both possibilities and not to necessarily assume that everything that we do is going to be helpful.
Another online question. How can we evaluate political structures and their impact on public health programs in a way where we can truly create impactful changes within the community and health organizations? What steps can those of us who are public health professionals best use to help? Somewhat related to this.
Oh gosh, that's a lot. So I think I'm going to pick the part of this question that focuses on policies, because I think the level of discrete policies that impact health outcomes is very often the level of politics that social epidemiologists are sort of most comfortable working at, right? And I want to make the argument that in order to understand how a discrete policy, let's say, to take an example from Leah's work, 10-minute rest breaks for workers working in heat. Alina, you also worked on this paper, yeah. So 10-minute rest breaks for like construction workers who are working in high temperature conditions. How does this impact health outcomes, you know, on the job, injuries or illnesses or what have you? Well, if you want to understand the impact that this policy has, you need to not only look at the data that you have that allows you to look at health outcomes among workers who are and are not exposed to these policies, but you also have to understand the selection process that created the data that you're working with. So, what do we know about how these policies are implemented? What do we know about the surveys that are in place and the sampling frames that they use? Are they really sampling the people who are most exposed to these working conditions, or are those people missing from our sample? What do we know about the underlying ideologies that might have prompted a municipality to impose or to, you know, legislate in this way, and the underlying ideologies of the people who wrote the law preempting the city from actually implementing this policy, right? So we need to know a lot of contextual information to understand the results that we're seeing. And I think, again, in an environment, in a scholarly environment where clean causal identification is what is prioritized, without a lot of attention to understanding the surrounding context, which is what actually allows us to make the case that this is a causal effect rather than merely a correlation, right? There's nothing magical about causal inference that gives you a causal effect. It just gives you a really, really precisely defined correlation. right? And all of the information that you need to understand whether that correlation is truly causal comes from the surrounding context. It's not part of the design, right? So if you want to move from thinking about policy to having a more structural understanding of what is actually generating the results in the environment that you see, a really good first place to look is at that surrounding context. Again, temporally, spatially, sociodemographically, those are three good ways to sort of think about unpacking context, but there are others as well. And that, I think, ultimately is going to lead you to look a little farther upstream to develop that structural competency. And then what you do with that information on the other end in terms of feeding back into policy, I think kind of I'll refer back to Gabe and Anna's questions and comments on that front.
Thank you, it was wonderful, and I love hearing the political side, the political angle, the political science angle here. I think we don't hear that often. I'm wondering if you've done work in Europe and you've done work in the US, and something I've encountered over time is that sometimes when you try to make statements about potential policies or potential societal organizations that may improve health in the US, the answer is the US is a special place. Nothing that works there works here because X, Y, and Z, and X, Y, and Z vary depending on the health outcome or the policy or the societal structure that you're looking at. How have you been able to, to convince people that those things happening over there may also have an influence in what's happening here, or maybe useful to think about what is happening here?
Yeah, so one of the most discouraging comments I ever got in speaking to someone in the policy world, she was a former health staffer, congressional health staffer, and I was asking her, well, I do all this work on Europe, and how do I get this information into the hands of policymakers? And she said, you don't. She said, policymakers at the federal level in the US have zero interest in looking to Europe. And in fact, most of them have less than zero interest. They are like overtly hostile to it. So that's one answer to your question. You don't. But the second answer is carefully and sneakily. Okay. So, I mean, one of the things that I've devoted a lot of time to over the last, let's say, 10 years of my career is working with the World Health Organization European office. So the European office is the office that's probably most aligned with sort of mainstream social epi as it's developed both in the US and Europe. It takes those lessons seriously and seeks to build tools that are then implemented through its relationship with the European Union at the European level and then pushed down onto country governments. So, one thing you can do is you can work in other countries and hope that eventually, the US will respond. But I think the fact is, it is becoming abundantly clear every day, more and more clear that the US is not, in fact, a special case. Comparative political scientists have been sort of sitting here over the last 5 years or so, twiddling our thumbs and saying, we told you so, right? There is nothing about the United States that makes us immune from either the political or the health pathologies experienced in the rest of the world. So I think external forces may be working in our favor in a weird way. But in all seriousness, I think you can't actually uproot institutions, and policies from, let's say, France and stick them in the United States and think that they're going to have the same effect. That's not how it works. And so again, understanding what are the key contextual factors that make something work the way it does in Paris, and can we create or facilitate some of those contextual factors in, let's say, San Francisco, right? That's how you get that sort of transfer of results. You have to have really in-depth contextual knowledge and sometimes work on the contextual conditions before you can do the direct work on the policies. So I guess that's the serious, non-snarky answer to your question. Sorry it took me so long to get there.
Questions?
Hi, I'm Cassie. Anyway, kind of go back on that, point, one of the earlier points you made, answering Usama's question. How can we, because obviously communication is like necessary for this. How can we communicate to people like in politics and everything who might think that they are an epidemiologist, but they're not? And also without them calling us like socialists and communists and every other name in the book, except for like rather than address our concerns. Sorry, I will be snarky, but how can we go about that to actually like show them that there does need to be a change? Because also I think some people think that like health issues are not their problem. Like I know in my master's program, I wrote a policy letter to the governor about something that I learned and talked about in my class. And I'm pretty sure I just got like a copy of like a template letter with my name inserted. Because obviously nothing's happened. So like, how can we really navigate these like tough challenges without it leading to like some of those more like volatile conversations?
Yeah. That's a great question. So I think I have sort of a two-part answer. One is that communication without relationships is not likely to get very far. And so building relationships with people in the policy world, building trust through common undertakings, is probably going to help a lot more than tweaking the language of whatever ask you're making, right? So really relationships are the key to communication. The second part is that when it comes to language, I think that we can sometimes do a better job at building bridges than we do. I'm sitting here in a friendly audience and I'm just like snarking away, right? But this is not how I talk to normal people. So I'm very much influenced by some work that I did like early in my postdoc career, where I just talked to people, like ordinary lay people, about their understandings about health inequality. And one of the things I took away from that is that conservatives are moved by many of the same ideas as progressives. Things like fairness, equality, opportunity. We all care about these things. We might define them slightly differently, right? But we believe in these things. And I think you can paper over some of the differences if you're not too explicit about it. When you communicate with people who might think you're, a rabid socialist, if you focus on values that you share. So again, I think being in relationship helps because you know what people's values are. And so not being afraid to kind of team up with people who you might disagree with about many things, and trying to find some of that common ground, I think is probably the best way to make sure that your communication actually gets heard.
All right, we're at time. So please join me in thanking. Yeah.
Yes.